Welcome to this explainer. Today, we're going to take a bit of an architectural tour of one of the most dynamic and frankly complex structures in the human body, the breast.
We're using a spatial, outside-in roadmap today. First up, the external landscape. Second, beneath the surface. Third, the lymphatic network. And fourth, changes through life.
External landscape, geography of the chest. We're starting on the surface before peeling back the layers.
Now, right off the bat, it's absolutely crucial to emphasize that breast anatomy applies to both sexes. I know we usually focus heavily on the female breast, but we really can't ignore this anatomy in men. In men, the structure is a lot simpler. Essentially located nipple, an areola, and some flat tissue bordering the chest wall. This is in direct contrast to the female mammary glands, which just have a much more complex internal structure that we're going to explore in just a second.
So, where exactly do the breasts sit? Geographically speaking, they rest right on the anterior chest wall. Picture them spanning vertically from the second or third rib all the way down to the sixth or seventh, sitting directly over your major chest muscles. That's the pectoralis major and the serratus anterior. And then horizontally, they stretch smoothly from the edge of the sternum, or your breastbone, right over to the mid-axillary line, which is essentially the middle of your armpit area.
Looking a little closer at the surface features, the center of the breast has the nipple, which is made of pigmented erectile tissue, and that's surrounded by the areola. And what's really fascinating here is that the pigmentation of the areola varies naturally depending on a person's skin tone. It can range from pink or light beige in lighter complexions, all the way to medium brown or almost black in darker complexions. Oh, and if you look really closely at the areola, there are these tiny little bumps. These are sebaceous glands known as Montgomery's tubercles, and they're just scattered alongside hair follicles right on the surface.
Moving on to section beneath the surface, the architecture. Let's look at the machinery and scaffolding hidden beneath the skin.
And this brilliantly illustrates what happens when we move inward. The foundation relies heavily on the ribs and that pectoralis major muscle. Just above that, the breast itself is a highly complex, customized mix of glandular tissue, fibrous bands, and fatty tissues. Now, the exact proportion of these tissues isn't static at all. It actually varies widely depending on a person's age, their weight, and their gender.
What's super interesting here is how the glandular tissue is arranged. Notice the upper outer section. There's a small triangle of tissue that actually projects right up into the axilla, or your armpit. This specific little extension is known anatomically as the tail of Spence.
Within that glandular tissue in women, there is an incredibly precise manufacturing center. To put a number on it, each breast contains between 12 to 25 glandular lobes. You can think of these lobes as the primary milk production facilities of the breast, and they're strategically arranged right around the center.
Let's look at how this internal plumbing actually works. Those 12 to 25 glandular lobes, they contain tiny structures called alveoli, which are specifically responsible for producing milk. But once the milk is produced, it doesn't just sit there, right? It travels through a highly specialized plumbing system made up of lactiferous ducts. These ducts act as direct transport pipelines, carrying the milk from each individual lobe straight to the centrally located nipple.
But you might be wondering, how does all this heavy, complex tissue actually stay in place on the front of the chest? Well, the answer lies in Cooper's ligaments. These are strong, fibrous bands of tissue that attach directly to the chest wall musculature. You can basically think of them as the crucial structural scaffolding, or the suspension cables, that hold everything up and give the breast its supportive shape.
The lymphatic network, drainage and defense. This is the breast's hidden security infrastructure. The breast is deeply integrated with the body's lymphatic system, holding several lymph node chains that serve very specific drainage zones. Try to mentally map these out with me. The pectoral nodes handle fluid from the anterior chest. The brachial nodes manage the arm, while the subscapular nodes take the back. High up in the armpit, the mid-axillary nodes act as a central hub for all three of those. And finally, the internal mammary nodes specifically drain the mammary lobes themselves. It is a highly organized fluid management system.
So why does this invisible drainage network actually matter to you? Connecting this structural knowledge to real-world health applications is incredibly important. Understanding these specific node regions, especially the ones right around the axilla and chest wall, is the absolute foundation for clinical breast assessments and global health awareness campaigns. Because the crucial point is this: since this drainage network is so extensive and so efficient at moving fluid away from the breast tissue, it is, unfortunately, the most common route for the spread of breast cancer cells. And yes, this applies equally to both men and women. Recognizing exactly where these lymph nodes are located really explains why medical professionals pay such close attention to the armpit and collarbone areas during physical examinations.
And finally, changes through life, an evolving structure. This intricate architecture is definitely not static.
In fact, this structure transforms completely across 4 major life stages: puberty, the adult reproductive years, pregnancy, and menopause. Let's walk through this timeline.
Development usually kicks off as an early sign of puberty, generally between ages 8 and 13. Physically, it starts as the breast and nipple protruding as a single mound of flesh. As a woman moves into adulthood and her reproductive years, this structure responds heavily to the menstrual cycle. Hormonal fluctuations can regularly cause the breasts to feel full or tender. It's really a continuous, highly dynamic cycle of structural response.
But the absolute most dramatic structural expansion happens during pregnancy, and that's driven by hormones from the corpus luteum and placenta. During pregnancy, the areola enlarges and gets much more deeply pigmented. Those Montgomery's tubercles we talked about become very prominent, and you might even see a venous pattern as the veins engorge. The breasts enlarge significantly because those alveolar cells and lactiferous ducts are rapidly proliferating. After pregnancy, during breastfeeding, they become exceptionally full and firm, before eventually decreasing in size once feeding actually ceases.
Let's move to the next stage and see how this builds. After menopause, the internal composition of the breast alters drastically once again, but this time it's driven by a decrease in estrogen.
With that significant drop in estrogen, the glandular manufacturing tissue actually atrophies. It basically shrinks and gets replaced by fatty deposits. And remember the architectural scaffolding we discussed earlier, the Cooper's ligaments? During this phase, those ligaments relax. Because they're the suspension cables holding the whole structure up, their relaxation means the breasts hang more loosely and become smaller and flabbier. The nipples may flatten out, and internally, the ducts can actually start to feel a bit like firm strings.
Clinical assessment of the breasts and axilla. Whether you're a seasoned pro just refreshing your technique, or a student trying to nail down the foundations, we are breaking down the exact visual and tactile protocols you need to really master this absolutely vital aspect of patient care. Okay, let's dive into this roadmap. First, visual inspection of the breasts. Second, breast palpation methods. Third, examining the axillae. And finally, evaluating and documenting lumps. Visual inspection of breasts. Now, as you know, in the wider world of physical assessment, we focus heavily on the classic sequence of assessment, inspection, palpation, auscultation, and percussion. But for this specific region, you can go ahead and put your stethoscope away. Our focus here is entirely on masterful inspection and highly sensitive palpation, and the whole shebang begins with your eyes. When that patient is in front of you, there are a few very specific things you need to be actively scanning for. First off, check out the skin itself. Normal skin should be smooth, totally undimpled, and perfectly match the color of the rest of the patient's skin. You are specifically looking out for any edema or swelling, because that can indicate lymphatic obstruction and could actually be an early, subtle signal of cancer. Next, check the overall size and symmetry of the breasts. Now, don't freak out over a little asymmetry. It's completely normal for a lot of adult women, and you'll typically find that the left breast is naturally just a bit larger than the right. Finally, zero in on those nipples. Note their size and shape. If you spot a nipple that's newly inverted, dimpled, or creased, it is absolutely crucial that you pause and ask the patient directly when they first noticed that specific change. But you can't just inspect a patient while they're sitting there in a single, relaxed posture. You've got to get them moving through specific positions to reveal what might be hiding under the surface. First, have the patient raise both arms directly over her head. Next, ask her to place your hands firmly on her hips and press inward. So why do we do this? Well, contracting those underlying pectoral muscles can suddenly reveal subtle skin or nipple dimpling that literally just wasn't obvious at first glance. Finally, if the patient has larger or pendulous breasts, have her stand up, place her hands on the back of a chair, and lean forward. This suspended position is just fantastic for unmasking any subtle breast or nipple asymmetry. Palpation methods. Transitioning over to the physical, tactile phase, your technique and your attention to patient comfort are totally paramount. You never want to palpate a patient who is just lying flat on their back. Have them lie supine for sure, but pop a small pillow right under the shoulder on the side you're examining. Then ask the patient to put her hand behind her head on that same side. This brilliantly simple little adjustment spreads the breast tissue evenly across the chest wall, making it significantly easier for you to detect any hidden nodules. Now, if the patient has very small breasts, leaving her arm at her side is totally fine. But for most folks, that arm up position is a real game changer. And when you actually go to palpate, you're going to be using the pads of your 3 middle fingers. So there are a few different patterns you can use to palpate the tissue systematically. First up is the circular method. Starting way out at the outer edge of the breast, you use those 3 middle fingers to gently but firmly rotate against the chest wall, slowly spiraling your way inward toward the nipple. The key takeaway here? Ensure you're pressing deep enough to actually feel the tissue against the chest wall, not just gliding lightly over the skin. Or you might prefer the wedged method. Think of the breast kind of like a bicycle wheel with spokes. You start at the outer periphery and palpate inward along a straight line toward the areola. Then you move outward along the next spoke. And you just keep going until you've methodically covered the entire 360 degrees of the breast tissue. And this brilliantly illustrates a third highly effective technique, the vertical strip method. You start at the top of the breast and palpate downward in a straight line, move slightly over, and palpate upward in the next line, creating this overlapping grid pattern. I really want to highlight that according to the American Cancer Society, this vertical strip method is considered the absolute most effective way to ensure that zero breast tissue is missed. Now, whichever of these 3 methods you personally prefer, you've got to be consistent. And whatever you do, don't forget to include the periphery and the tail of Spence. That's that upper-outer extension of tissue that reaches right up into the armpit. All right, so you have meticulously covered the entire breast mount. But hold on, you aren't quite finished with palpation. The final, crucial step is to palpate the areola and the nipple itself. You need to gently squeeze the nipple between your thumb and index finger. And what are we looking for here? You're basically checking to see if this pressure produces any sort of fluid discharge. So what happens if you actually find something noteworthy? How do you ensure the next provider can find that exact same spot without playing a guessing game? Well, we use 2 standardized mapping methods. The first is the quadrant method. You just mentally divide the breast into 4 intersecting quadrants: upper inner, upper outer, lower inner, and lower outer, plus a 5th segment for that tail of Spence. Alternatively, you can use the clock method. You visualize a clock face superimposed right over the breast, with the nipple dead in the center, and you describe the location by the hour. So you might note a finding at, say, 2 o'clock. But listen, whichever method you use, you must always measure and record the precise distance in centimeters from the nipple to the lesion. That exact measurement is the magic key that allows another provider to find the exact same spot later. Examining the axilla. A clinical breast assessment is totally incomplete without evaluating the surrounding lymph node regions, right? Because the lymphatic drainage primarily flows right into here. But before you even start palpating, please exercise a little clinical empathy. Warm your hands up first. Seriously, this can be a pretty uncomfortable area for the patient. Have her relax her arm and actually support her elbow with one of your hands to take the weight off. Then, cup the fingers of your other hand and reach high into the very apex of the axilla, right behind those pectoral muscles, pointing toward the mid-clavicle. From up there, you press downward and inward toward the chest wall to feel those central nodes. Normally, these should be soft, small, and totally non-tender. You also need to systematically check the pectoral nodes along the anterior axillary fold, the lateral nodes along the upper inner arm against the humerus, and the subscapular nodes by pressing inside the posterior axillary fold. Now, if you feel any nodes that are hard, enlarged, or tender, stop right there. You should immediately move up to assess the supraclavicular nodes by the neck for comparison. Evaluating and documenting lumps. Which brings us to the really critical final phase. This is the moment that requires absolute clinical focus. What if you actually detect a breast lump during your assessment? Finding a mass instantly shifts your brain from general screening mode into active investigation mode. We need a really clear, logical flowchart to evaluate this finding so we can document it perfectly for a potential biopsy and follow-up. So the crucial point is that your documentation literally cannot be vague. It must be highly precise. If you palpate a lump, you have to record 6 specific characteristics. Number 1, its size in exact centimeters. Number 2, its shape. Is it perfectly round, discoid, or totally irregular? Number 3, its consistency. Does it feel soft, firm, or just rock hard? Number 4, its mobility. Can you slide it around under the skin, or is it firmly stuck in place? Number 5, the degree of tenderness when you press on it. And number 6, its precise location, using either that quadrant or clock method we just discussed, and obviously including the distance from the nipple. Let's look at how those characteristics actually help us build a differential diagnosis. It's kind of like a giant puzzle, and this matrix breaks down the classic presentations of different masses. Look at a fibroadenoma. That's a benign mass. It is typically very mobile. It feels almost slippery under your fingers. It's round, firm to soft, and usually non-tender. Now, compare that to fibrocystic disease, which are benign cysts. These are also mobile and round, but they're often multiple, and they are commonly tender, especially right before menstruation. Now contrast both of those with the classic presentation of a malignant cancer. A cancerous mass is usually fixed in place and single. Its shape is irregular, maybe even star-shaped, definitely not perfectly round. The consistency is firm to hard, with poorly defined edges. It is usually entirely non-tender, and crucially, you will frequently see skin retraction or dimpling associated with it. Understanding these defining features is exactly what allows you to quickly recognize when a case requires urgent, immediate further investigation. As we wrap up this explainer, I really want to emphasize your vital role in this whole process. You see, your job isn't just to perform this exam flawlessly in the clinic. You must actively stress to your patients the critical importance of having regular clinical breast examinations, and you have to make absolutely sure they know exactly how to perform breast self-examinations at home using these very same principles we talked about today. By teaching them what their normal baseline feels like, you empower them to notice the second something changes. Mastering these basic foundational steps quite literally saves lives. So ask yourself, what subtle clinical sign will you catch tomorrow? This is the big question, isn't it? I mean, is every breast lump an immediate sign of danger? We're going to tackle this head on. Our whole objective today is to build up your clinical intuition, definitely not your fear. By the end of this explainer, you're going to be able to spot the difference between what actually needs urgent attention and what, might just be a completely routine, benign change. So here is our roadmap for today. First, understanding breast cancer types. Second, visual signs of concern. Third, benign breast conditions. Fourth, lactation and breast disorders. And finally, male breast health matters. Understanding breast cancer types inside the tissue. Well, before we can even begin to spot the abnormal, we absolutely have to know what normal looks like, right? Beneath the surface, it's like a landscape. We've got lobules, fat, dense fibrous tissue, and then the pectoralis muscle resting right behind all of it. And when a lump develops, it can pop up literally anywhere in this landscape, even reaching right up into the axilla or the armpit area. Visualizing this invisible anatomy is just absolutely crucial, because this is the exact environment where these abnormalities actually take root. So let's take a look at an infiltrating or invasive ductal carcinoma. When you're palpating or feeling this, it typically presents as this irregularly shaped mass, and the edges are poorly defined. It is definitely not perfectly round or smooth. Physically, it feels kind of stuck or fixed in place. It's firm to hard, and usually it's non-tender. You might even notice some skin retraction on the surface above it. That fixed, irregular feel, that is a major, major clinical red flag. Now, on the complete other end of the cancer timeline, we have what's called ductal carcinoma in situ, or DCIS for short. Let's break down that kind of intimidating medical term. In situ basically just means in its original place. So this is breast cancer in its very, very earliest stage. The cancer actually starts right inside the duct itself. And if it's left unchecked, that's when it spreads outward into the breast surrounding parenchymal tissue. Catching it at this early in situ stage is exactly why thorough assessments are such a game changer. Visual signs of concern. Reading the red flags. So a really crucial visual red flag is a condition called peau d'orange, which, if you translate it literally, means orange peel skin. And that hits the nail on the head. It's this edematous thickening and pitting of the breast skin. It gets that really striking appearance because of lymphatic edema happening right around deepened hair follicles. Now, while this is typically a late sign of breast cancer, it's super important to keep in mind that it can also happen if there's a breast or axillary lymph node infection, or actually even with Graves' disease. Let's talk about the structural mechanics of two specific surface changes, dimpling and nipple retraction. Dimpling is essentially a puckering of the skin, and it happens because the skin is abnormally attaching to the underlying tissue. A lot of times that's due to an inflammatory or malignant mass pulling on it. Nipple retraction works in a really similar way. Basically, scar tissue forms within a lesion, and as that scar tissue shortens, it literally drags the adjacent tissue inward. This causes the nipple to deviate, flatten out, and eventually retract completely below the level of the surrounding breast tissue. Next up, we really need to define Paget's disease so we have the right context for the visual evidence we're about to look at. This one is a rare form of breast cancer, and the tricky thing is, unlike a deep tissue lump, it usually starts right on the surface. It shows up as a red, granular, or kind of crusted, scaly lesion specifically located on the nipple or the areola. And here is what that actually looks like in reality. Paget's disease presents as this really stark red crusted lesion right on the nipple. Over time, it can ulcerate and cause actual erosion of the nipple itself. And because, at first glance, it can so easily be mistaken for something simple like dry skin or eczema, paying incredibly close attention to these surface changes is absolutely non-negotiable during a proper assessment. Benign breast conditions. Not every lump is cancer. I want you to think back for a second to that breast cancer mass we discussed earlier. Remember? Irregular, fixed in place, hard. Okay, now contrast that with something called a fibroadenoma. This is a totally benign tumor that is round, lobular, and really well demarcated. When you feel it, it's actually slippery, firm to soft, and it's freely mobile. It moves around. It's also usually non-tender and causes zero visible skin retraction. Feeling that distinct, slippery, mobile boundary is a huge differentiator, for sure. Another incredibly common benign finding you'll see are fibrocystic changes. These are essentially just benign cysts. Much like the fibroadenoma, these are round, mobile masses, but they tend to feel more elastic, and they are commonly tender to the touch, especially around the time of menstruation. You might even notice multiple cysts at the same time. And again, just like the fibroadenoma, you typically won't see any evidence of skin retraction. Lactation and breast disorders. When nursing goes awry. Here we really have to differentiate between two completely distinct lactation disorders, mastitis and breast engorgement. So mastitis is an active external infection. It happens when a pathogen, very often from the nursing infant's own nose or pharynx, invades the breast tissue through a cracked or fissured nipple. This disrupts normal lactation, and the breast becomes tender, hard, swollen, and warm. Now, engorgement, on the other hand, is more of a mechanical or plumbing issue. It's caused by venous and lymphatic stasis, combined with milk just accumulating in the alveoli. It does cause painful breasts that feel heavy and warm, but the key here is that it's driven by fluid and milk buildup, not by an invading pathogen. And finally, male breast health matters, breaking the stigma. A lot of times, men who experience breast disorders might feel really uneasy or embarrassed, maybe viewing the whole thing as unmanly. But the clinical reality we have to face is that the incidence of breast cancer in males is actually on the rise. And when it does happen, it almost always localizes right in the areola area, which means that a gentle, thorough professional clinical assessment is literally just as critical for men as it is for women. Now, let's talk about gynecomastia, which is the abnormal enlargement of the male breast. Interestingly, the causes differ wildly depending on age. It's kind of a tale of two demographics. In adolescent boys, this is usually just a temporary stimulation of breast tissue caused by estrogen. Once adequate testosterone production really kicks in, the enlargement almost always stops. But if we look at elderly men, gynecomastia is typically driven by age-related hormonal alterations or even by certain medications they might be taking. From a clinical perspective, gynecomastia might be barely palpable, and it is usually bilateral, meaning it affects both sides. But here's something really vital to keep in mind. Beyond just age-related hormones, this can actually stem from some pretty serious systemic issues. Things like cirrhosis, leukemia, thyrotoxicosis, illicit drug use, or heavy alcohol consumption. So it's definitely a symptom that demands a really comprehensive health review. Okay, before we wrap this up, I want you to keep an eye out for these rapid-fire symptoms in literally any patient. First, nipple discharge. It can be totally normal, but if it comes with other changes, it could signal an endocrine disorder, cancer, or blocked ducts. Next, breast pain. This is commonly benign, like from the mastitis or fibrocystic changes we talked about. And lastly, visible prominent veins. Now, while visible veins can indicate cancer in some patients, remember that context is everything here. They are considered entirely 100% normal in pregnant women simply because of standard engorgement. Wow, okay, we've covered a tremendous amount of ground today. We've moved all the way from the internal structure of invasive carcinomas to the visible surface signs of dimpling, and we even explored benign cysts and male breast health.